Yeah, good morning, everybody. And I don't know if some of you saw my name flashed as Rucha Gupta. So I've been variably called as Richa Sharma, Richa Gupta. So it's interesting, but then a lot of other people also saw it. In the interest of time, I'm going to keep this very short and just highlight a few salient features. So as we all know, the glucose target, so pregnancy is a very special condition, a very specialized condition, wherein the debate comes up as to what should be the glucose target. Number two, why are we trying to manage this? And of course, it is to prevent maternal and fetal complications. So the audience is well aware that we have these targets. The preprandial glucose per the ACE recommendations, we like to keep it close to 95. The 1 hour 140 and the 2 hours 120. And if they have pre-existing type 1 or type 2 diabetes, even before they go into pregnancy, we try to keep this even tighter. Similarly, the ADA has very similar guidelines as have been outlined over here for you to see. So before we, of course, begin treatment of diabetes during pregnancy with medications and insulin, medical nutrition therapy, which could be a whole talk by itself, which I have not included in the topic today, is certainly of huge importance. In fact, we always guide our patients as to how many grams per carbs. And as we just heard our previous speaker also tell you that moving, so even after walk after every meal seems to bring down the sugar levels quite dramatically. So of course, when we start thinking of treating with pharmacologic agents, insulin, and certain other medications, namely metformin and sulfonylureas come to mind. However, I will only focus about the my talk on insulin. So basal insulin that we know, NPH and Deramir have been approved. Prandial insulin analogs are preferred, but also if the patient cannot afford in our setup or where I work in the civil hospital, regular insulin is also being used. So as you can see listed is the pregnancy categories over here. So NPH and Deramir still have a category of B. Glargine and Degludec, we do have some studies on Glargine now, and we do use Glargine. I'm sure quite a few of you are using Glargine. Pump therapy, so continuous subcutaneous insulin infusion is something which is rapidly coming into favor. We have some good data emerging with that. And of course, teaching your patient about carb to insulin ratios as to how should they bolus for their meals is also something that is very important. So here are your various insulins that are safe for use during pregnancy. Your bolus insulins, namely with a peak onset anywhere from 15 minutes to 60 minutes to 2 hours. And your long-acting insulins, which most of us are not using NPH anymore, but we prefer to use in the place of that Deramir and in my practice also Glargine. Okay, so when you start using insulin, when should you initiate therapy? How will you titrate it? And then I'll just try to save 3 minutes for questions with the panel over here. So the fasting glucose level, if it starts to rise above the various targets that we just talked about, that is where, and when medical nutrition therapy fails, we are going to start initiating treatment. Insulin dosing guidelines during pregnancy, intrapartum, intra-labor, and also postpartum. So this is a rough guide from Dr. Jovanovic's recent publications that we have also, that from 1 to 13 weeks, you can do this based on the body weight, 0.7 times the weight in kilograms. Once we start getting into the second trimester, the insulin requirements are going to increase. So you can go from 0.8 to their weight in kilograms, and finally moving on 0.9 to weight in kilograms. What you will notice is that this insulin requirements are high in the last trimester and the last month, but you can see how they fall dramatically to pre-pregnancy levels once the baby has been delivered. So as we are well aware, we try to use about 30 to 40%, even though the guidelines say 50% for basal insulin. And then based on the meals and how many times they are eating, you need to divide up the bolus doses to prevent hypoglycemia, to attain euglycemia. And lastly, also, we want to make sure the patient is comfortable with multiple injections. What is most required is strict monitoring of blood glucose. So just a word about CSII during pregnancy. The benefits of this might be that it mimics physiologic insulin secretion. The patient does not have to inject themselves, so the psychological trauma of having to do various injections might be taken away, and it's safe and effective for management of gestational diabetes, type 1 or type 2 diabetes if it was pre-existing. Certainly there is the cost of therapy, and the patient needs to be a little bit smart in order to manage this. So what we really want to avoid is hypoglycemia, because hypoglycemia can lead to several complications, not just for the mother herself, but also for the baby. So when you want to treat the hypoglycemia, I'm just going to skip this slide because the audience is well aware about how we would try to treat hypoglycemia. Now here is what I just wanted to show you, is why are we trying to go for this tight glucose control during pregnancy? And so what you can see is in favor of tight control and routine care. So tight control will help to prevent any serious, perinatal complications, as well as shoulder dystocia and therefore the risk of prolonged labor. However, it did not seem to reduce the amount of admission to neonatal nurseries. Jaundice requiring phototherapy was also reduced. So certainly you do have better infant outcomes when you control the glucose tightly. A word on SMBG, and then I will just open this up for questions. So insulin requiring patients, the minimum they need to perform is at least more than 3 times per day. And really the more number of times they will check and the better they get used to doing this is going to be a better idea. CGM, you've heard a lot about it in the last 2 days. Certainly CGM devices can be used, and they'll be useful in the patients who are unable to achieve the target glucose levels. And this has been shown to reduce the risk of macrosomia when we use CGM in these patients versus no CGM. Okay. Thank you very much, and I just would like to open this up for questions.
Good.